How are you, sir? How are you?
Good afternoon, everybody. Welcome to the inaugural Intestin Banff workshop. We are excited to welcome all of you pioneers to this workshop that's been evolving over probably a couple of years. I want to thank Deb Sudan for really initiating this process, and Kim Solis and Mike Mengel and the Banff team for allowing us to enter the Banff process after a lot of deliberation and to give us this opportunity. This is meant to be very much interactive, so I'm just going to ask all of you to come as close as you can to participate. We have a packed 4 hours, and where we would like to go over the critical histologic criteria for intestinal rejection, and then develop a path forward for further challenges in the field. We need everybody's input. Our other facilitators today are Deanna Cardona from Duke, Marion Raban from Paris, and Phil Reese from Miami, but all of us are going to be expected to participate and to contribute to the product of this meeting. Let me just turn it over immediately to Kim Solis, who's going to give us an introduction to the Banff process, and again, thank you, Kim, for welcoming the intestin community.
So you can't imagine how excited I am by this. I know you're excited, but we haven't had a new organ in Banff for over a decade. So I mean, this is really something nice for us to find that we are expanding in this way. And I found this cute graphic to go along with it. And I'm kind of discovering that your area of medicine and pathology is kind of where the action is. I really realized this before. In every other organ, we talk about stem cells, but they're really mysterious. No one knows where the niches are, and they never see them, and they're just a theoretical entity because the epithelium turns over really relatively slowly compared to the GI tract. But your epithelium turns over every four to 5 days, and the stem cells are part of the recognized histology. So it is now known that there are, in fact, for a long time, it's my understanding that it was believed that there were 14 cell types in the GI tract. But now, based on single-cell transcriptomics, there are actually 51. So that's the greatest increase that I'm aware of. And so it really expands every story you want to tell about the normal or diseased GI tract, that the number of players is now substantially greater than what you thought, because there's so many different cell types, and they still need to be characterized. What do those 51 cell types do? What are their lineage and relationship to each other, and so on. So I don't want to take too much time from your meeting, but I thought I'd talk about something that makes Banff really unusual, and from the beginning, and that is that we do something illegal. Believe it or not, if you look up consensus generation, no matter where you look, you will find that the source you've happened upon tells you you need a professional facilitator. The characteristic of that person would be that they know nothing about GI whatsoever. They have no knowledge about what you're generating consensus about, but they know everything about generating consensus. They can come in the room and teach you a new way to think, and you put Post-it notes all over the board, and And we just have never believed in that. So that's not how we do it. We have expert, moderated consensus discussion. And what does that take? That takes humble leadership, because if you come in all macho and testosterone infused at my way or the highway, then that's never going to work, because you'll never allow anyone else with a conflicting view to speak, right? So the way we moderate is being particularly polite, kind of a Canadian politeness. If we find that the majority of people in the room are buying into someone else's idea, then we let that person speak more, and so on. So that's what these slides are about. So this slide talks about the idea of the profession of the professional facilitator, and such a person has never been at a Banff meeting, so we don't use them. We respect what they do in other spheres. Now, granted, if you're dealing with life and death, or where somebody in the room is going to be incarcerated or harmed in some serious way, then having expert-led consensus doesn't work very well. But the kinds of things we generate consensus about are not quite as scary as that. And so they're in a realm where you can actually be polite to people with varying opinions, and it actually works to have an expert-led consensus generation. So that's kind of what we've done since the beginning. Now, this building that is pictured here, it is the Trans-Canada Pipeline Pavilion at the Banff Center. That building still exists. That's where these meetings began. It's where they were held in 91 and 93 and 95. And it's very close to the building where we will be next time. So next time we will be in Banff at the Banff Center. They have a new building there that can accommodate 470 people, which is just about right for us. And is a really great place to be. And it's a very honorable location too, because you know now with the present rules about interaction with pharma that we're not supposed to hold meetings in luxury resorts, right? And this is not a luxury resort. The thin walls, the sort of simple furnishings in the rooms, but it works just fine. And it's like going back to school to some extent, or like being in college, or whatever you want to say. So listening with a point of view, that's what this is called when you have expert-led consensus discussion. And so the person playing the dual role of leading that discussion has two mindsets. It's trying to lead, but also be deferential to people with varying views. And that can certainly work, so you raise the issue that is to be discussed, state your own views, ask for reactions from the audience, respond to participants' comments as a facilitator, would paraphrase, draw people out. If you think that another point of view is not well understood because it's been presented too briefly, ask the person questions. But you'll also find that the audience thinks you're a really cool person if they realize that you're being deferential like that and like drawing out opposing views and stuff. That makes you look like you're really on top of things, you know, that you're not like insecure about who you are and your own persona and so on. You've really got it all together if you can act like that. After at least two moves of facilitated listening, give yourself the floor to speak, make statements that reflect your own perspective, answer questions, and so on. So kind of being fair and then repeat these steps as often as needed. And so we've been doing this now for 28 and a half years, and it's kind of working. And the other spectacular thing about is think about the NIH. Most of you know what I'm about to say. The NIH used to do consensus conferences. And because the NIH conferences were beyond Dunbar's number, what is Dunbar's number? That's 150. That's what your brain is capable of, you having empathetic friendships where you really care about the other person, can sort of put yourself in their shoes. With 150 people, and that's your limit. So if you meet a new person, you try to create an empathetic friendship, you've got to get rid of one of the others because your brain's limit is 150. And at these meetings, we're kind of always at levels below that, where you can really look around the room and you don't mind caring about the welfare of everybody else there. In larger meetings like the ones that the NIH was having, you're constantly meeting people in the hallway that you hope don't start to talk to you because you don't want to hear anything about their personal life. It's sort of beyond what is convenient for you. And in that setting, people were gaming the system. They were thinking, well, how can we pretend to generate consensus at the meeting, but already know beforehand what we're going to do? And the NIH didn't really feel they had any way to protect themselves against them. So they gave up consensus meetings. Now, if you tell them you want to run one, they say, talk to the transplant people. So that's us, because they know that somehow we've been doing this successfully, but they reached the point where they were no longer successful at it. So it's quite interesting to think of doing something here that the NIH is not capable of doing because of a different sort of structure and size. Okay, any questions for me? But I want to warmly welcome you and tell you how important it is for us that Banff is expanding into the GI tract. That's very, very exciting. Any questions? Okay, then I'm going to sit down and listen.
Perfect. So I want to again welcome all of you in the room. I think one of the lessons that we heard from the Banff organizers very loudly was that it was important in this afternoon to have as much time for discussion and really iteration and feedback as we would allow for any presentation. So we're going to try to stick with that format. And again, we will hope that in the course of the 4 hours we can accomplish some really consensus building around some few key topics and then build for the future. The organizers and facilitators have been reiterating some drafts of the agenda, so I did try to hand out for those of you in the room a kind of current version that did evolve from the last one that we sent out by email. We tried to get feedback from IRTA and our professional community about the topics, and we've included those in the agenda. For the first part of the afternoon, we're going to focus on early acute rejection and T-cell mediated rejection. And the format that we've decided to do is to have a brief overview of the clinical monitoring and problems of rejection in intestine transplant that I'll do briefly, followed by some discussion with some note takers that will assign to kind of write what are the additional gaps that we identify. And then Dr. Cardona and Dr. Sudan are going to present a review of the literature focusing on T-cell mediated early acute cellular rejection, again followed by discussion. And then we're going to have our first group discussion around the concept of classification schema, looking at a straw man from the literature and having discussion around what additional components we wanted to add to that. Some of those are listed here, but others may come up in the discussion. And then we're going to have a break, a group photo to record the moment. In the second part, which we'll target to start around 4:35, Deb will kick it off and we'll focus on antibody-mediated challenges, both from a literature point of view to where we are today, as well as some future collaborations and challenges in inter-observer variability and other challenges that we face in this field. We want this workshop to lead to a summary description and a manuscript, and then for future steps together as a group building on this. So with that in mind, let me kick off our clinical overview. So I want to thank several sources. The IRTA, which is our Intestinal Transplant Society, is provided some data for this. Also, Mihail team, who is, I think, wins the award for the furthest travels for this meeting. I don't know how many hours and miles that is, but welcome, Mihai. He led an endoscopy monitoring workshop recently in Paris, which I will summarize very, very briefly. And then Maria Cristina Segovia from Duke had done a survey recently that I didn't want to duplicate, so she graciously allowed some of the data on immunosuppression practice among intestinal transplant centers, mostly in the United States. This will kind of set the backdrop for what we're, with the kind of clinical material that we see in our field right now. We'll touch base briefly on this state of clinical monitoring and immunosuppression practice and identifying some gaps in discussion. Again, I also want to note that we'll use some data from the SRTR as well as the other sources that I mentioned. The IRTA has been condensing data from almost 100 centers since 1985, although more recently 46 active centers have contributed updated data since the Terasaki Research Institute began to support the database for the IRTA. And this has been recently updated and was presented in larger form in 2019 at the IRTA CERTA meeting. The key kind of take-home message, I think, for our pathologists and clinicians and those of you maybe who are newer to the field are that there has been a evolution of activity, but despite trends that may be downtrending to a certain level in intestine transplant due to the improvements in rehabilitative techniques for medical and surgical therapies, there is still a significant body of patients that are surviving with their allograft throughout the world. So this summary of the global experience demonstrates that we're following in our current database over 2,000 adults and children who have received a variety of intestinal grafts, including isolated small bowel transplants, liver and small bowel multivisceral combination unblocked transplants as listed there. So I would consider these 2,000 to be our mandate in terms of the patients that we're responsible for globally in our communities and our programs and around the world, and really why the people who may benefit from this this type of consensus building, because unfortunately the individual center experience is limited by the type of and dispersion of the practice across the country and across the world. Globally, pediatrics is about 50% of those survivors, about 1,000 patients, and as is shown in this IRTA slide, of the survivors who are currently followed, having been transplanted at age under 18. Focusing on the immune activity and most clinically pertinent part of the scenario for our patients is this slide, which is a 10-year-old slide, but is still accurate in terms of the relative rate of acute rejection by organ type in the SRTR database. You'll just notice that our intestine and thoracic colleagues share the issue of a higher than expected rejection rate compared to the liver and kidney, and one that we believe has more clinical significance. Although this is data from 2009, when we look at current practice, it bears out that there hasn't been a significant change. This is the SRTR data for our induction and maintenance immunosuppression trends. You can see on the left that although over the past 10 years there's been an increase in the use of T-cell depletion, which is in the green on the left, and IL-2 receptor antagonist therapy in the blue, that the overall incidence of rejection, I'll show this on the next slide, has not significantly changed. We're talking about acute rejection within the first 6 months post-transplant. The maintenance immunosuppression, which we'll summarize in the survey slide, is shown on the right, where tacrolimus and steroids form the bulwark of the maintenance immunosuppression at 1 year post-transplant, followed by a combination of MMF and steroids or other therapies. The SRTR most recent annual report demonstrated a 60% incidence in pediatrics in isolated intestine recipients and 40 to 30% incidence of rejection in other age groups or organ combination. And for the most part, we'll talk a little bit in our discussion. For the most part, intestine transplant is not HLA matched. So the majority of the adult data that's shown here indicates an intestine transplant is HLA. A mismatch is not according to HLA matching. Let me turn to a couple of the survey data that were provided by our colleagues. This is the immunosuppression strategy data that was collected by Dr. Segovia, and I understand she's preparing that for summary publication. Many of the collaborators in the room are present here today, and she sends her regards. This survey, which I believe was presented recently at the international meeting, surveyed centers that were performing at least 10 intestinal transplants recently, or between the last years of 2015 and 2017, and had a variety of questions. We're going to focus in this presentation mostly on the immunosuppression management and the transplantation across sensitization. It was representative of the centers doing a significant activity, over 10 transplants across the U.S. And I just highlighted a couple of the pertinent slides for the basis of our discussion. First, most centers do transplant across DSA presence. The tendency to, there was one correction that didn't come through on the slide, for DSA class 1 mismatch, the tendency was not to defer transplantation in the presence of a class 1 mismatch, whereas the opposite was slightly more true in class 2 DSA, where the majority, a small majority, did not transplant across the class 2 DSA that was present in the pre-transplant screening. Most induction was done with RETG, although other 4 centers out of the 10 included rituximab in their induction practice. This summarized a lot more data that I didn't have time to present, where she found that most centers do perform HLA DSA testing before intestinal transplant, checking titers at a variety of frequency, but usually after 3 months or sensitizing events. And I mentioned the practice across transplant positivity, DSA matching positivity. Strategies for desensitization were always also included, but differed across centers, and most centers did use RETG for induction. The standard immunosuppression regimen, as shown from the SRTR data, was tacrolimus with steroids, and you can see the centers that also included MMF and mTOR inhibitors, 20 and 30% of the centers surveyed, respectively. The trough level immunosuppression is higher than that used for other solid organ transplants, with levels in 7 out of the 10 centers of 10 to 15 in the first 3 months post-intestine transplant, and then less than 10 beyond 12 months after transplant, with some other outliers as shown. And then follow-up DSA testing was in the pre-intestinal transplant at varying intervals, and as well as post-transplant. One of the issues for discussion will be the role and timing and interpretation of protocol biopsies. Although there is variation in practice and there is some evolution of this, most of the surveyed centers did perform protocol biopsies even in the face of overt symptoms, and they were done at a weekly interval. And this was a summary of the survey data that we've discussed. Most centers did run immunosuppression lower with a liver-containing graft, and most performed protocol biopsies even in the absence of symptoms. The practices for pre and post-transplant DSA varied, but were somewhat similar across centers. But there were widely varying strategies and goals for desensitization, if any, and for the diagnosis and therapy of antibody-mediated rejection. And then finally, Mihail's team gathered a group of participants at the IRTA meeting in Paris to look at endoscopic surveillance, and that complements this data, and surveyed the practices across the centers, which is shown here. Again, the issues that they wanted to address were the timing and practice of endoscopic surveillance across the centers that are active currently, and then try to answer some questions about what could be standardized by asking when, how frequent biopsies were done, where the samples were occurring, what tissue site, and then other practical considerations of prepping for these procedures. You can see the centers that reported and their frequency in the first year and then afterwards. These were the areas that they looked at through a survey, and I asked Mihai and Deanna and Deb to add on to the survey interpretation. In terms of when to start, by surveying the individual centers and the frequency of rejection and the timing of their first rejection, is shown here on this representative slide. You can see that the early day at first rejection varied from 7 days at the earliest to a longer interval, but the mean was about 15 days. And this was in both adult and pediatric patients. The summary of the questions that they had were most centers are doing endoscopy early after the first week. Usually weekly, and then with the interval dependent on the findings. Most are doing 5 to 10 centimeter fructostoma in pediatric recipients and 15 centimeters in adults. Again, this is not to account for some practices in centers that are going to avoiding stoma or doing only symptomatic biopsies. Most centers reported about 3 to 5 biopsies per session, and most centers focused on the ileum. There was not data here, although we can ask Mihai about colonic biopsying in these centers. And so these are a very high-level overview of the clinical monitoring. What are some long-term implications? I think everyone is familiar with this in the audience. Clearly, the intestine and our thoracic organ counterparts have the poorest projected graft failure half-lives by organ. This is older data. Again, this is data through 2009 that was reported in 2011. But you can see on the left that although the intestine had an improvement of the graft half-life, it only was improving to the area of about 4 years from the SRTR. This is adult data. And on the right side, you can see the yellow line is the early attrition, and the colored lines are the late attrition at 3, 5, and 10 years. And you can see that for all organs, including the intestine, early attrition has improved to low levels, but the attrition rate after 1 year has remained stable in the intestine, and it does have the lowest half-life. And this is reflected in the graft survival era, that although it has improved over era, is mostly due to early improvements and that early attrition improvement. And we believe that there's an association with DSA that has been published in clinical series, and that is associated with the development of chronic rejection and graft loss, as is shown in this summary of the Pittsburgh experience. So to conclude, where are we from a clinical standpoint before we talk about the pathologic literature and what's been established is that we are in a time period where intestine transplant is a rare disease. We are doing less than 150 intestine transplants in the U.S. Yearly, although it's fluctuating. Right now, it's not with systematic use of HLA typing or cross-matching. ACR, at least severe ACR, is problematic and a source of morbidity, and there's a narrow window between therapy and toxicity. And the monitoring for rejection, although it's evolving, we do have the challenge as clinicians of interpreting early changes in minimally symptomatic patients. That's one of the areas we want to discuss. And we believe that this all has a long-term impact on graft function. So we have a few minutes. I just would like to open up for discussion in terms of additional clinical gaps that the audience would like to contribute before we move into the literature pathology review. A couple of minutes. Mihai, can you comment on any other additional learning from your survey that didn't capture here in the presentation?
I think we focused too much on the first several months. We didn't do that much of the monitor. Something I was studying that in the workshop. So I think what we never considered was for instance, to rescope when to repeat the scope after getting a rejection. That never came up in that's the real issue. That's something that perhaps we can work on.
Other comments from the clinicians?
We're seeing more cases of presumed ALR. All solid organ version. We have a lot of good treatments. I think we need more data on that. The survey actually brought out the fact that there really is no how to deal with this.
Yes, Jen?
The other thing is that data that we presented from Miami, I specifically wanted to remain the same. So that is the older era before 2013 before we started with the hospital. Our rejection now is a lot less, 20 to 35% within the hospital.
Okay. Yes, ma'am. Yes, please.
The issue between biopsying the small bowel and the colon, how should we approach that? Should we be consistently getting colon biopsies? I'm the pathologist along with Dr. Koh, Mount Sinai, and we sometimes get the colon biopsy and small bowel biopsy, and sometimes we don't. So should we have some consistent regimen as to when to get both or when not to get?
Great question. We're going to cover a little bit of that, but a quick response from the clinicians or in the room.
We do because since we don't do ostomies, and we have to get the sequence biopsies and transfers. And we had never really isolated a lot, a few cases of isolated a lot.
One comment to Jennifer's earlier comments, since we moved to biopsy only for cause. Our incidence of rejection overall is about, in last reported, 39%, depending on very the cohort, 35 to 40% or so, and just about half of them are severe acute. I'd be curious to know if anybody thinks mild and moderate are important from the point of view of graft loss. What does that mean? What is finding of C4D in the setting of severe acute cellular rejection mean in the absence of capillaritis? And finally, to the protocol biopsiers, what is a finding of planned rejection in a patient who is clinically doing well?
Last question, and then we'll move on. I'm going to write these questions down.
One of the concerns that we had at our place, and then in the discussion, because the Cambridge focus is quite a bit about studying and comparing colon and ileum in the same, taken in the same cells to see whether rejection in one means predicts rejection in the other. And the fact of things is stoma. So we were stuck in the colon, we were just trying to get into the ileum without, and then we were stuck only with colon biopsies, which was fine. And should we trust those as a surrogate for ileum? Yeah, thank you for that. But I think we should try to gather some evidence about the fact that it push forward to go upstairs and go to the tumor and do something else. But that's like the practical implication of this question, I think, when you cannot get into it.
Great. Good discussion. I'll write those questions down. Let's move on to the review of the literature, part one, with Dr. Cardona.
Good afternoon. Thanks to Deb and to George for inviting me to participate in this, I think, kind of exciting endeavor. So my task was to kind of bring us up to speed on where we are in the world of pathology and diagnosing both acute T-cell mediated rejection and antibody mediated. And so we kind of broke this up into the first half focusing more on cellular and then the second half focusing on antibody mediated. So, as I mentioned, on this first part, we're just going to talk about cellular. So where are we now? So back in 2003, 2004, there was the first large kind of, or the 8th annual symposium, and consensus was achieved. And they agreed on using a certain set of guidelines as far as diagnosing rejection on pathology. But that symposium also kind of expressed the need for a standardization. And I still think that's going to be one of the big topics for today as well. I think the other thing that paper and that symposium really focused on was the need to have ready access to relevant clinical information. And as a pathologist, that's still something that I struggle with sometimes, where it's not readily accessible at the time of the pathology review, certain very key, essential clinical pieces of information. Then they also set, adequacy processing standards as far as how you handle biopsies when you receive them, how many biopsies should you have, how many different locations, etc. And as I mentioned, they also reached a consensus as far as the diagnosing of cellular rejection. So what was it that they used? So in essence, they used the Dr. Wu paper, and it looked at rejection as far as indeterminate, mild, moderate, severe, and it really focused on epithelial apoptosis as like the first key indicator of rejection, as well as varying degrees of lamina propria cellularity, and then increasing severity of crypt injury that ultimately develops into ulceration or detonation, and that's obviously the most severe form of rejection. And here's just the pictures actually from that paper looking at that range of indeterminate, where you just have minimal to mild apoptosis, not really hitting that greater than 6 per 10 consecutive crypt threshold, then mild hitting that threshold, moderate getting more severe crypt injury, and then again severe, you get pretty much denudation, ulceration, and dropout of the crypts. So in looking at all these papers, I kind of wanted just to get an idea of what's the experience as far as how often we diagnose rejection. And I try to just choose a couple of the papers that I think were focused on the incidence by patient, because depending on the paper, sometimes it was like, oh, we read 3,000 biopsies and 5% of them had this and 10% had this, and not down to the patient. So these were looking at the percentage of patients that developed rejection. Some were looking at just the first year. When Deb and I put the Duke data at the bottom there, it's all comers. We have several cases of late rejection that happen literally up to 9 years post-transplant. So it's not comparing apples to apples, but I do think that there's a wide range that we see as far as how often we're calling rejection in our population. And I think that raises some questions as why are we seeing that variability? Is it a difference in the way that we're reading the pathology? Is it a difference in how we're managing our patients? Or is it a difference on how we're surveilling these patients as well? And I think it's probably a combination of all the above. So some other things from those first kind of sets of paper was, A, severity of the rejection actually did correlate with an unfavorable outcome. So there is some degree of importance as far as having severe rejection stand out compared to the mild and to the moderate, which I think goes to your question earlier. And then a lot of those severe rejection episodes happen early on, within the first 3 months, and definitely the vast majority within the first 12 months of transplant. But then we're still seeing several cases of late rejection. Why is that happening? And then also, the duration of the episode of rejection also correlated with the grade, which kind of makes sense. If you have really severe rejection, it's going to probably take longer for that patient to recover from that episode. So once we make the diagnosis of rejection, unfortunately, as far as my job, it's not done. And obviously for the clinicians, it's not done either. But there's this question of like, all right, well, is the patient getting better, or do they still have rejection going on in the background? Well, once you have severe, moderate rejection where you're knocking out crypts and having ulceration, it can be a really hard question to answer. This paper was looking at, well, what are the changes several weeks post that initial insult that we're seeing in the biopsies? And you can see that 1 week out, you're still seeing evidence of mucin depletion, which means it's a very regenerative epithelium. Up to 4 weeks out, you still see that kind of nuclear prominence or that really reactive appearing, epithelial change. And then even 2 weeks out from that insult, you're still seeing evidence of increased apoptosis compared to that control group. So does that mean that there's still rejection going on, or is this just reflective of the fact that the bowel has to heal following that initial insult? And from the pathologist's point of view, it can be really difficult to make that distinction sometimes. So what are other things or tools that we can potentially use besides just histology? And so there's calprotectin, and we can look at the stool and see if we're seeing increasing levels of that marker in the stool. You can look at citrulline levels in the serum, and if they're decreasing, then that also would correlate inversely with the fact that you've got possibly rejection. And then there's also genetic profiles, right? So if there's specific gene profiles that are being overexpressed, could that help us predict, potentially in those cases where we're debating, well, is it ongoing rejection, healing rejection, could it help us distinguish whether we can sit tight and just let the patient heal, or we actually need to continue and treat that patient? So with this, I'll let Deb first two case.
Thanks, Deanna. That's a great introduction. So I have two real cases from our practice. And so the first one was an 8-month-old female. She had been diagnosed with gastroschisis. She'd had multiple strictures, multiple surgeries, eventually resected a large amount of bowel, created an ostomy, and she was on full TPN. Despite multiple attempts at feeding, she became jaundiced, had bridging fibrosis on her liver biopsy at about 5 months of age, and really had no hopes of weaning. So at that time, she underwent a transplant evaluation and underwent a transplant at about 9 months of age. Post-op day 1, we started her on Prograf, put her in G-tube. She had steroid induction. She did not get any depletional induction therapy. She underwent routine surveillance biopsies on post-op day 8, 14, and 20 with no evidence of rejection on any of those. And on post-op day 22, she was known to have severe exfoliative rejection, sort of out of the blue. She was treated with thymoglobulin, 6 milligrams per kilo. Her target Prograf levels ranged between 15 and 20, and she had a very prolonged and slow recovery with intermittent infections, a lot of diarrhea, electrolyte abnormalities, but was eventually discharged home. Despite regeneration of the mucosa initially, however, she was not able to absorb her nutrients, and she did remain TPN dependent until she was eventually retransplanted approximately 10 months later. I think do you want to go through the slides? Okay.
Yeah, so here's just a great example of pretty good severe rejection. There was marked increase in epithelial apoptosis. You can start seeing the tissues just kind of falling apart because it's ulcerated on the one end. And the crypt is just kind of being destroyed. We did do C4D because we saw areas where there is mucosal hemorrhage, potentially some thrombi, but we weren't certain, but our C4D was negative. And this was when it was actually explanted out, and you can just see that it was just completely denuded.
We had a second case. This patient was a 15-year-old female who had been admitted for fever, emesis, melena, and abdominal pain, and she was 6 years after an isolated intestinal transplant for jaundice, short bowel syndrome, and loss of venous access. She underwent a biopsy at that time, which revealed severe acute cellular rejection with ulcerations. Occasional crypts were identified, but largely destroyed. She was treated with a total of 7.5 milligrams per kilogram of thymoglobulin and did again have some regeneration of the epithelial lining. No DSA were identified during this episode of rejection or in the follow-up time frame. Her course was, of course, complicated due to the high levels of immunosuppression by multiple infections, including a Klebsiella UTI, rhinovirus, and RSV infections during her hospitalization. Although she experienced a lot of abdominal pain which persisted well beyond the regeneration of the mucosa, she was eventually discharged from the hospital, but like the first patient, actually never regained enteral function and remained TPN dependent. She was discharged, as I mentioned, about 2 months after she was treated with sublingual Prograf. She really wasn't even able to tolerate oral Prograf, but we were able to achieve target levels of about 15 and prednisone at 20 milligrams daily. We continued to attempt to reinitiate feeds on an outpatient basis over many, many months, eventually being unsuccessful. She had many admissions for partial bowel obstructions during this time frame, and we really believed she had chronic rejection at this point. She had central vein thrombosis, including an SVC syndrome, developed severe neck and face swelling, and eventually was reevaluated for transplantation. During that evaluation, she had a liver biopsy showing extensive fibrosis. She had been jaundiced at her initial intestinal transplant, although we didn't isolate a bowel because she was not cirrhotic at that time. We did believe she may have had some hepatic venous outflow obstruction and Budd-Chiari syndrome, and eventually was relisted for combined liver, small bowel, pancreas, and right colon transplant 8 months after the severe rejection episode. She did undergo retransplantation 3 months later. She did have a mild cellular rejection at 6 and mild to moderate at 7 months. She did develop DSA at that time, which was not, or I'm sorry, HLA antibodies that were non-specific, a DQ4, 8, and 9, all at fairly low levels, less than 5,000 MFI, but no DSA during this time frame.
So again, pretty similar to the last case that we looked at, really severe evidence of rejection, tons of epithelial apoptosis, and just clear ulceration on the surface. In this case, C4D was not performed, and I can't tell you.
So these are discussion questions.
Yeah. So, so these were some of the questions that, in trying to put this talk together, I was thinking of, and in talking, with George, Deb, and Marianne, as far as, one of the things as far as pathology goes is when we get a biopsy, it truly is just a snapshot in time of a very dynamic process. And so we need to have all the other key data points available when making that assessment. So whether it's key clinical information, any additional biomarkers that might be available, molecular testing, anything that can help us assess, because it really is a dynamic process. So, the things that we rely on most, is going to be the apoptosis, and that's like the first thing that we're looking for when we're looking for a biopsy. And you might think that that would be an easy call, but even amongst pathologists, there might be just not a general agreement on what you're going to call apoptosis. And so, should we come up with a consensus on what we feel should be adequate kind of histologic appearance for apoptosis, because that's where we kind of start as far as assessing for rejection. When looking at the grading schema of rejection, do we feel that there needs to be further refinement? Is 6 the right cutoff, right? Should we make that higher, lower? Do we feel that we maybe are overcalling or undercalling rejection? And I think that can be a very local kind of thought process. Deb may or may not have said at one point to me, I think we're overcalling rejection. But I think she's changed her mind. So what's the role of eosinophils, right? Do they play a role in rejection, or could they be a morphologic clue that maybe it's not rejection and it's maybe allergy, a drug reaction, some other mechanism of disease, and not more immunosuppression is needed? Laminar cellularity, is that an important feature for us to still focus on, right? Because that is one of the things that you look at for grading of rejection. Then we talked about the debate on when you have an episode of rejection and now you have these morphologic changes still smoldering in the background, how do we make that distinction of, yes, continue to give them more immunosuppression or hold on tight and let's see if they continue to recover. Then there's the whole question about, small bowel versus colonic rejection. Is it the same beast? Do we use the same criteria when calling one or the other? Right now we're getting biopsies, when possible, from the bowel, from the transplanted colon, and from normal colon. Hopefully that normal colon acting like that baseline, right? So that we can distinguish the changes in the other ones, are they significant or not? Or if they all show the same kind of changes, then maybe it's not rejection, it's something else, right? So do we have a consensus on how we approach just what the biopsy should be, where they should be? Then there's a social clinical history that I mentioned. I feel that as a consensus group, we should recommend that there are key elements that should be available to the pathologist at every single interpretation, if at all possible, right? Are there biomarkers that we would propose should be part of an algorithm, right? Can we as a clinical team come up with an algorithm at the same time that you're doing a biopsy, you're also sending for XYZ testing? There's augmented endoscopy. Is that something that we should recommend as far as targeted sampling? Are there advances in the field of endoscopy to help them actually better biopsy the areas that might demonstrate evidence of disease? I don't know if we're there yet or not. It's just more of a question, right? And then the microbiome, that's like a hot topic on everything. It cures cancer, I think. But is that something that's impacting the risk of our patients developing rejection, right? Should that be something we should be assessing on our patients? So these are just kind of just food for thought for us to kind of maybe start a discussion.
Perfect. Thank you. So now is the time where we get to work, okay? Thank you, Dan and Deb, for that introduction. I think perhaps just to get the discussion started, why don't we focus on your first 2 points about epithelial apoptosis and then refinement of the current grading to begin our discussion and get the group. Could I have a volunteer to scribe? One of our pathologists who would like to be a scribe on the apoptosis and the grading criteria. Any volunteers? You have a volunteer for us? No, you have a question? Okay. All right. Okay, for one question. Any volunteers for scribing for us? Okay, you want to take we have some Post-it notes. I'm just going to kind of keep some notes for those as we kind of go over topics of apoptosis and grading criteria. If I have no volunteers, I'm going to have to call Kishore to do it. So, okay.
Right, I'm pretty legible.
Perfect.
Keep me quiet as well.
What color do you say?
What color?
I'm not fussy. Am I allowed to ask one question because I liked?
Yes, you are. It'll be the third question. Okay. Please let us know what your program.
I have a comment. I previously published my article in 2013 and 2012 in the American Journal of Surgical Pathology about apoptosis and findings. And in my opinion,
What's your name?
Yes.
Sorry,
Excuse me. I'm a pathologist, Tatsaki Tsuruyama from Kyoto University.
Okay.
Yes. And I published about finding intestinal transplant. So, in my opinion, it is a little difficult to make a diagnosis of epithelial apoptosis. Because how did you evaluate apoptosis in the intestinal transplant? In my opinion, finding of apoptotic bodies in the crypt is critical, but it was, to my experience, it was sometimes difficult to detect apoptosis. So in my hospital, we often use keratin fragment or tunnel staining for detection of apoptosis. How do you think about detection of apoptosis?
So there's a couple of people that I was asking your name to see if maybe I put one of yours in here. So this was one looking specifically at small bowel transplant. transplants. And I would say the image on your left is the classic exploding crypt cell that I would confidently say every pathologist should be able to identify that as a apoptotic body. That's not the ones that are usually an issue. The ones that are on the right, where it's just little bits and fragments of the karyoptic debris, those are the ones that cause a lot of debate. Is one little fragment enough? Do you need to have a cluster of them? Do you still need to have that halo around the little cluster? And so in this paper, what they demonstrated was that in diagnosing rejection, if you use simply the classical definition, the concordance was amazing. It's great. Kappa 0.9, I mean, I would love to see kappas of 0.9 every single day, right? But when you use the more liberal definition of apoptosis, obviously that score goes down. And I think that that's something that we need to kind of decide, are we going to allow for being liberal or stick to our guns as far as the classical definition of apoptosis, or like you said, utilize, there's caspase 3, there's tunnel assays, there's definitely various markers that we can definitely use. Where a lot of my research has been done previously was in graft versus host disease. Interestingly, when we did the NIH consensus document for that, we actually decided not to use that because it over-counted. It led to more false positives than we wanted. So, but I mean, again, that's something that we could look at and see if it would be different in our population.
Behind and then Robert.
Quick question. How does the handwritten intestinal biopsy look like?
So, how is there any criteria for an adequate intestinal biopsy for kidneys? So many glomeruli. How many crypts should we look at? Because again, if you look at FSGS, if you cut the glomerulus here, it's different if you cut it here, and you can lose the apoptosis over there. It's 2 or 4 the same. So I think that could be a good starting point. How many crypts would you like to look at? If they're gone, they're gone, so there's nothing to look at. But if it's something in between, when should we say? That's good.
Question for Rami and then.
Yeah, I'm Ranga from Pittsburgh Children's. So technically speaking, yes, answering your question first, I'll come to your question shortly. I would use the bigger hypoptosis. I only go with the bigger ones because the smaller ones can be a pitfall in that they may be inflammatory, so the apoptosis that you're looking at, lymphocytic apoptosis, and you're going to be falling into the trap of calling it. So I have trained our clinicians clearly on that, transplant surgeons, that I only call the larger ones, and if there are smaller ones, if I'm seeing them in unchecked, I basically want to see a gap in the epithelial cell nuclei. If I see a gap in the nucleus, if I see a discontinuous epithelial nucleus when it's lining the crypts, to me, that apoptosis is probably an epithelial cell apoptosis. I agree that it depends on the stage you catch it, because apoptosis is only there for about 20 minutes in the body, so you have to catch it in that 20 minutes. But the point is, if you start counting the smaller ones, you are going to invariably fall into the trap of overcalling rejection every single time. And as far as the second question of adequacy, I use minimum of 10 to 15 crypts per biopsy. If I have 10 to 15 crypts, that's enough for me to make a diagnosis of rejection or not. We have to remember the caveat that an endoscopists never biopsy the worst areas of the bowel. You'll see a big ulcer there and they leave the ulcer and go to the edge of the ulcer because they're afraid to touch the ulcer for bleeding. So there's always that caveat that the intestinal interpretation or rejection may vary from piece to piece within the same bowel. So that is always a caveat. So you have to correlate with the endoscopic finding. If the endoscopist says there's ulcers there, whatever you may see and you call mild rejection, you're probably calling the wrong rejection grade. Anyway.
Hi, I'm Mabel from Mount Sinai. I thought that this topic is really interesting. How many crypts would you need in order to be adequate? But practically speaking, what we get, we just score. So sometimes if there are no crypts, it's clearly severe rejection. It doesn't really matter that there's no set number. I think it's probably more when you're thinking about, is this mild rejection, or is this something that should be actionable? When you have enough crypts, and then you're also looking at are those really apoptoses? Those sort of kind of gray areas, I think, would be a great would be something for discussion to have clear criteria. You know, if we're looking at something, we're trying to decide if it's mild rejection, do we have enough crypts there? I think that would be probably most appropriate. And then the other question I had is, if at that 6 apoptotic body cutoff, was that done on the conservative popcorn, or was it done on you know, the liberal, where you have a couple little pieces? I mean, where was that when they decided to do 6 apoptotic crypt cutoff? What were they looking at?
It wasn't described.
It wasn't described.
We have one comment and then Jake.
Mabel, having worked with both Norm Harpaz and Margaret Maggot at Mount Sinai, because they were 2 of the 6 authors in the original paper, I learned from them that they counted even the pinpoint apoptotic bodies when in the original paper. So the popcorn bodies were taken into consideration and counted as 1, so as well as the pinpoint fragmented bodies. So separate this another apoptotic body.
Comment from Jake and then
So, when I look at transplant biopsies, I'm not as literal as that. I put everything into context. If I see a fragment of one nucleus, that is an apoptosis to me. I look at the rest of the biopsies, and we routinely get multiple ribbons on the slide, so I just look at the levels across to see if more show up. And if more don't show up and there's no other apoptosis, don't call it. But the 6 was derived empirically about when patients were symptomatic, and we pretty much used the classic definition of the full apoptotic body. And I agree with the speaker that apoptosis was first recognized on H&E sections, and for me, it was very accurate.
So this is another paper real quick, and I know Phil wants to say something, that for GVHD cases, we also reached a round robin consensus. This was a German-Austrian consortium, and we did allow for the cardiac debris to count, but there had to be at least 2 clumped, like 2 small fragments together for it to be significant. And one little speck, we called it the little Horton who, the one little speck didn't do, but you had to have at least 2.
So, I was the one that wrote the paper, and when we were trying to put this data together, I remember that question coming up exactly. But actually, when Maggie and everybody were trying to put this data together, we said, well, let's go ahead and try it both ways. And we actually did it so that at the point where 6 was with popcorn, apoptotic bodies, or the other ones, it also depended on the time post-transplant. So there's a lot of things that were critically important as to the types of apoptosis when they showed up. And so that was one aspect. But what I also wanted to bring up was the point that Jake just made up, is that you can't literally just be working on apoptotic bodies. This is a whole dynamic process of the biopsy. This is how much information, what's the character of the information, what's the architecture, and most importantly, what does the clinician see endoscopically? Endoscopically, and is the patient having poor production? To me, is number 1, 2, and 3 most important, and then it kind of prejudices us on how we look. The other point I wanted to bring up is, unfortunately, these patients have many comorbidities and infections, early PTLD, preservation issues. All of these things also contribute, unfortunately, to GI pathology. So I hope that sometimes we're making the right call, but if this is a patient, like Jen Garcia may be telling me, this patient has some allergic symptoms and we have EOs, yeah, it could be contributing, but it also could be concomitant. So it could be an enteritis that's also occurring. So that being said, I mean, I would hope that we have, as Deb said, we need to have a very strict criteria as to what kind of information we are going to look at as a pathologist looking under the scope as to what kind of information is going on with that patient. So that was just an announcement.
Other comments?
Why don't we do something more like the GVHD criteria where, you have, is it, it kind of takes everything into account. When it's really bad, you have denuded, epithelium, loss.
I didn't hear the comment.
So the question was, why don't we use the same criteria that we do for graft versus host disease?
Or something very similar, because that kind of, when I look at that, weird projections, it's just like GVHD.
I think that for severe forms, it's gonna be identical. It's where we wanna set the threshold or the cutoff for calling it. It's funny because the same question but in reverse is being asked to us for GVHD right now. It's like, why is our threshold actually that low? Should we use a higher threshold like 6 per 10 cribs? So it's, yeah. I think that if you were to reduce it, first if you were to reduce it to the threshold for GVHD, you would be calling rejection on everybody.
So I have a two-part comment, which you gave me the perfect segue for the first part. I've always philosophically been puzzled as to why this grading started with indeterminate for acute rejection. It almost makes acute rejection an aspirational goal, and the pathologists clearly, perhaps not the choir, but under some pressure to find rejection. What Philip just said, there is so much else going on, and we talk about diagnosing rejection in the current pathological context, but it's more in the current clinical pathological context. So it's not just the right number of apoptosis in the right pathological background, but the right number of apoptosis in the right pathological background in the appropriate clinical setting. It's a little more, and maybe that first grade should be dismissed.
I would disagree with getting rid of that. That's the most common diagnosis in all organ allografts now.
Sure, and perhaps
The indeterminate rejection.
Yes, it's indeterminate because there's a risk-benefit ratio to treat the patient, okay?
How many of these patients will end up getting sick, especially in a pediatric setting where EBD is so common? And if you set a very low threshold for rejection and call
You may have
rejection.
misunderstood what I'm saying.
But I understood what you're saying, but people have tried to get rid of an indeterminate category for a long time. And the problem with it is the pathologist sees tissue pathology and damage, and the clinician is hesitant to treat. And you have to do something with it. And if you study every organ system, the heart, the kidney, the liver, the intestine will end up being the same. That smoldering activity doesn't bode well for the long-term outcome. So you can ignore it and get away and just say, don't do it. They do it in heart transplant. They call it 1R. So if you call it 1R, yeah, there's infiltrate and a biopsy. They don't treat it, and it means nothing. You know, they don't treat until it's a 2R. But if you have a 1R biopsy persistently over years, you do worse.
So there is no resting normal phase for an intestinal allograft?
When it's
Here's my
perfectly
question.
normal, just about. Yeah, I see normal.
Should be normal. It should be normal. So where is that in this scheme?
Normal.
Zero.
Zero.
No rejection.
Indeterminate.
Zero, it's like
We don't call it normal. We don't ever call it, we call it indeterminate. That seems the default in the answer.
You should be definitely saying normal.
We see a lot of normal.
Yeah.
No rejection. Yeah, no rejection.
Yeah, why is 60% not normal, or 50? Why is it not normal, or some other specific pathology? I get it, that there is concurrent, confounding, intercurrent pathology, or even smoldering pathology that looks worrisome but doesn't meet criteria. I get that. My question is, if, especially to the protocol biopsiers, with all the protocol biopsies we have accumulated in asymptomatic, clinical cause-free patients, so are we, by definition, saying there is no, really, every intestinal allograft or biopsy is in some phase progressing towards rejection? It's just not up there yet. That's what it sounds like.
pre-apoptotic, so two is normal, and less than pre-apoptotic is kind of probably borderline normal, I don't know.
If you don't
Would you
have
mind,
the data, how are you gonna do follow-up, long-term follow-up?
Would you
If you
mind
ignore the
going back to
category
the
and
showing
call them
up the
normal.
classification schema up on the screen? Thanks. Great, so Jen.
I have a question for the clinicians. How often are you treating indeterminate? Are people treating indeterminate colorectal expression?
I'm not, no, we're not.
No, maybe rebiopsy sooner.
Exactly, I was gonna say
Yeah.
the same. Typically, if we find indeterminate, we'll rebiopsy relatively quickly, rather than waiting a week to do the repeat biopsy.
Especially if it's in the early post-op.
Especially in the first, 6 to 8 weeks post-transplant.
So is there consensus on this? This is a great discussion. We're doing okay for time right now, but is there consensus that the indeterminate category, even in an asymptomatic patient, has value in description histologically? Is that the consensus from the group?
As long as it's not the default. I mean, if you really are seeing like a high incident and indeterminate, then there's something wrong there.
Yeah, my concern is it often is a default. I could be wrong.
So in that situation, I'll say the pathologist is indeterminate.
All right, we have Rob and then Jake. I'm trying to get another microphone. Let's try to keep just one person speaking at a time, just so we can learn from everybody.
Sorry, just a comment or a question, Kishore. Could that be the difference in centers that are doing just for cause biopsy, where you may see higher prevalence of indeterminate versus centers that are doing protocol or surveillance biopsies?
Actually, no. Since we started doing for cause, we almost never say indeterminate. Our incidence of indeterminate is, we see normal or not normal.
Back to the indeterminate, looking at the published grading, localized inflammatory infiltrate, minimal localized inflammatory infiltrate, minimal crypt injury, increased apoptosis, but less than 6, no to minimal distortion, no mucous ulcerations, changes insufficient for the diagnosis of molecule rejection. What would you edit? What would the group edit from that in light of our discussion, if anything?
If we call non-specific changes and take out the acute rejection.
I think Jake,
No,
but go ahead, Jake.
What other organ doesn't have this category? This would be the first. Small bowel would be the first.
Okay, Jake is saying that.
Your point's well made.
That's a good point.
Lung, heart, kidney, liver, pancreas, they all have this category. It's very hard to get rid of. It's attractive to get rid of, but you can't. And this is one of the biologic problems in transplantation. What do you do about these grafts?
We've been puzzled by this issue. I don't know if we have enough experience, but what we've seen is that first of all, we see some apoptosis in general in normal small intestinal biopsies that are biopsy from non-transplant patients. But in those cases, there is also a little more inflammation than the immunosuppressive patients, which could be the cause of it. We kind of consider that, I'm from Columbia Medical Center, and we kind of consider between 4 and 6, between 4 and 5, we consider indeterminate, and less than 3, no evidence of rejection, or no definite evidence of rejection. I thought that was a kind of like 2 or 3 apoptotic bodies would be the threshold for the right normal.
Yeah, I think you really got to emphasize whether the patient's pediatric or not. You have to be very careful with pediatric patients.
What's your distinction about pediatrics?
Well, the EBV is always lurking below the surface in pediatric patients, and you've got to be vigilant about it, or you get yourself in trouble quickly.
That was a good point, though, that you were bringing up about the other entities also bring up a lot of the changes, and that's why we call it indeterminate, because there can be other inflammatory changes. Indeterminate biopsies, again, as they were originally described, were not normal. These do not look normal. This has got altered architecture, increased inflammation, some apoptotic bodies, which could be enteritis, could be a viral process. but it could also be autoimmune. And that's the point. Like, until we can prove that at a molecular level, functional level, or post-treatment level, I think I personally would have to have some type of category, dirty as it is. It's, I mean, I don't enjoy doing that with kidneys, I enjoy doing that with other organs, but it is not normal looking either. So that was the other point.
We have your run, and then,
So maybe one question to the pathologist. When you look at both the definition of indeterminate and mild, this is a collection of findings. However, there's no word regarding the end or. I find occasionally situations where a pathologist will come and tell me, oh, there are more than 6 apoptotic bodies. The child is perfect, there's no inflammation. They may call it a mild rejection occasionally. And I guess that if we're thinking about the overall, also the inexperienced centers, whether there is a need to use some words like end and or, and not just the list of findings.
Or subclinical rejection.
Right.
That's
Just to
So
clarify
because
that,
but the question is, when you write something like that, is there a point to add some wording around that?
so just, we have 2 microphones, a little feedback. Is there a benefit then to discussing the and or? It wasn't explicitly mentioned there, but I think that's a good point. Should we include that in the final description? Seems so.
George, may I follow up to Yaron and Rob's comment? The need for that second biopsy in my mind, that quick follow-up biopsy, 2 days, because this is not right, not enough to treat, but the biopsy is not right, comes sometimes from in my home, not from in the town.
Well, I think it depends though also if they're symptomatic. So if they're having diarrhea and they have an indeterminate, then you're kind of on the fence whether or not you're going to treat, because maybe it really is rejection, or maybe actually they have norovirus that hasn't been identified yet.
So another thing that I just wanted to add, because I see a lot of pediatric transplants, so we tend not to see a lot of inflammatory infiltrate in our biopsies, even when we're seeing a lot of apoptosis, and we're calling it mild, but we don't have this inflammatory infiltrate. So that's the other thing, like when we see these very tiny little apoptotic bodies, but they're clustered in one single crypt, so more than 2 or 3 of those pinpoint in one single crypt, even in the absence of a background mild inflammation, we're sort of at that stage where we want to call it mild, and it's reaching, or at least more than 6 apoptotic bodies overall. The inflammatory infiltrate is not convincing. So does anybody else have that? You see that a lot of pediatrics.
I don't pay attention to the inflammatory infiltrate other than neutrophils.
To be honest, I don't pay attention to inflammatory infiltrate, and I can tell you that some of the patients get so over immunosuppressed or treated, if you see early on, they don't have a lymphocytic infiltrate to mount any response to sometimes the cryptic injury and damage. And I have focused on the apoptosis, and I don't pay attention to the inflammation. Of course, I do make sure if there is increased inflammation and if it looks very activated lymphocytes, then I would exclude a possibility of EBV and other things, definitely. But by itself for rejection, inflammation is not a criteria for me.
I agree. It's variable. It really just depends on how immunosuppressed the patient is at that point. If you see it, great. If you don't see it, it doesn't necessarily change my mind. But usually if you see the apoptosis, there is something else, like whether it looks injured, you start seeing a little bit of atrophy, it may not be the inflammation, but you do see other changes than just apoptosis.
I guess my question would be, are we overcalling indeterminate? If we are, then maybe it would be good to add in the and or, because if we're just focusing on apoptotic bodies, we're going to tend to overcall and call things mild when there's just apoptoses and not too much other things going on. But if we don't want to miss, if those patients are important, the ones that have those crypts that have 3 or 4 apoptotic bodies in those 1 crypts, and we want to treat those patients, that's a decision we're going to have to make. Do we want to not count that as mild acute rejection, or is that something that needs to be treated? And I guess our clinical colleagues are the ones that need to tell us, where should we set this threshold?
So I would pose the same question, but put it in a patient who comes in 1 year post-transplant for this clinical follow-up, completely stable, has nothing like that, and all of a sudden we have a couple of biopsies that have apoptotic bodies. Do have an increased infiltrate, have a little bit of blunting. So that's where I think, again, the teamwork issue with the clinician, I would think they wouldn't treat. They wouldn't do it, but on the other hand, you're chronically, the changes that are going on, that's not normal gut. That's the other side.
It does sound like there's some consensus around including an and/or in the indeterminate category.
Even for mild ACR, I think inflammation is not a requirement for mild ACR. I've got so many, I've shown you so many rejections without the inflammatory component really being there. And if there is inflammation, to start worrying what else is going on. Is there an injury component? You see neutrophils and all, which you shouldn't be seeing. Or is it a portending a worse rejection that's coming, or you can biopsy an ulcer in the vicinity?
That's the other concern.
Right.
So you're suggesting, we have a comment here, you're suggesting
And
or for both. And just, what about specifying to the other comment of the pathologist to put a number, something between 3 to 6 apoptotic bodies for indeterminate, or 4 to 6, something like this? Is there some consensus around not including 1 to 2?
I use 3 to 6 generally as indeterminate, because 1 to 2, we don't know what you are, where you are, stuff like that.
Just for scribal purposes, when we're saying and/or, you're saying apoptosis and/or infiltrate.
Yeah, and/or inflammation.
We're talking, I think, in looking at this, sure, if you could say minimal inflammatory infiltrate and/or, so in between those terms.
So, I think it should be apoptosis and/or
Yeah, without.
With or without.
The main criteria. So start with the apoptosis, and then use the other criteria that we also see accompanying the apoptosis.
Yeah, with or without.
And
the question is,
yes.
can you call it if it's apoptosis only? If the answer is no, you start with apoptosis, and then you say and/or one of the following.
But just the end, not.
The whole list that follows after that. That's the question.
So
Just the
inflammatory, indeterminate, go ahead though.
Oh, I was going to say, the question though in the reverse, can you call it mild rejection if you only have everything except the apoptotic bodies listed? Okay. So it has to be and.
Yes, it has to be.
So apoptosis on it by itself is adequate, at least pathologically adequate. Even if anything not good.
Because with all the clinical information you have, I mean, if you have EBV infections, then you are a little bit in a dilemma. You still would be conservative anyway in that situation. But most of the viral infections don't cause apoptosis.
The point you just raised is important now, because if you do have other conditions that are just causing singular apoptosis, and you have nice, beautiful crypts and villi, and everything is pristine, and there's no inflammation whatsoever, that doesn't seem like, I think we would have an easy time of scoring that as rejection. Now, the patient had other things, like you're saying, maybe other confounding conditions, I don't know, but I wouldn't be very worried about it. Just calling on that singular finding, a pristine looking biopsy.
It's unusual.
Exactly.
It's unusual to find that scenario, but we're just putting it in there because we're trying to focus on the apoptosis more than the inflammation. Here it says you're looking first for the inflammation as opposed to the apoptosis. You're just trying to change the priorities, that's all. But it's well taken that you could definitely have other changes, very unusual to get your apoptosis and nothing else happening.
I'd like to segue to this question. I want to pose this to the group. What if you have a lot of neutrophils and lamina propria edema, and yet you have this, the diagnostic number for rejection?
We tend to lower our bar for calling it rejection despite having the greater than 6 apoptotic bodies or even popcorn bodies if you know that there is some concurrent enteritis, some the neutrophils and edema. So do we need to specify a specific number to call it mild, moderate, to give a grade of the, because of course you can have concurrent infection and rejection. So what do we do then? And the number of apoptosis should still remain the same because we tend to lower our bar for rejection.
We tend to biopsy a lot in that setting.
Right. We leave it to the clinicians to decide whether they want to treat the rejection or not in the scenario of infection, depending upon the clinical status of the patient. But what we see on histology, we can't run away from the fact of whether increased apoptosis and there is neutrophils. So we have to come to our balance.
We've had 4 specific recent cases within the last 3 years of severe acute cellular rejection in the setting of C. difficile enteritis, with pathological changes of form. It's just one example. I agree that it can coexist, but it's different.
I'm sorry, when you have like a very deep inflammation, kind of patch, and you have a few neutrophils, and it is apoptosis in those clinics, to me it's like an impression that it's from some form of very acute. Is there any start on that?
Most of the infections that exist come from the surface. It's from the lumen. Bacteria are in the lumen, so the infection is more towards the surface. It's unusual for infection. That's why we distinguish between IBD and infection by using inflammation cryptitis as opposed to surface epithelial inflammation. So inflammation in the crypts suggests that there is targeted injury to the crypts.
I would say the exception is viral. So I mean, you can have CMV that can look just like rejection.
But it doesn't usually cause apoptosis.
It's been well described that you get apoptosis with CMV infections.
Yes.
So if you have a liver transplant, look at colon biopsy, it'll look histologically like graft versus host disease, but it's their native colon or their native small bowel. So you can't just use cryptapoptosis to diagnose rejection. It's infection. So you're going to hurt more people that way than not. You have to rule out those kind of things. So unfortunately for me, I get a lot of small bowel transplant biopsies that are just an ulcer, and I never know what to do with that. Is that CMV? Is that ischemia, or is that severe rejection? So I just tell them the truth. It's an ulcer. I don't know what it is. I don't know what other people's approach is, but you have to be very careful with infection. You can't just call that rejection right out.
So
And
I have a
I
question.
think they have to treat the infection first, and then if there's a background rejection, come back to that.
How many institutions do protocol immunohistochemistry or testing for viruses, whether it's CMV,
You can
adenovirus?
still miss that in a small biopsy.
Correct.
Still can
I
be
just-
virus.
So on every biopsy, you do CMV and adenovirus? Oh, no, I'm talking about viral, so ruling out infection.
And I think Jake's point was that EDD can cause cryptapoptosis as well, and that's why you have to be careful.
Okay, we have one comment, and I'll summarize this section.
I wanted to also ask, from the clinical point of view, we're often left with the dilemma if someone has severe rejection, how are we adequately treating it? How long do we have to treat it? And I wonder, should there be a breakdown in people who have severe rejection as to recovery? Can we do that from the histological basis?
That's a great segue. I think let me summarize, and Jan and Deb and Phil, in terms of our summary discussion for indeterminate mild ACR, we're going to move apoptosis up in the category. We're going to put a number of 3 to 6 in the indeterminate category, and we're going to add the other criteria after the apoptosis. We're going to make a note about ruling out infection or other causes. Is there is that an adequate summary right now? We'll wordsmith some of these and send it out to the group.
So this we need to see what is 3 to 5 indeterminate or 3 to 6? How most people
And the greater than 6. We use 4 to 6. 3, in my opinion, is too low. You're going to overcall indeterminate.
All right. Now we have 20 minutes. So one area that is brought up is in the second category, the moderate ACR and the severe ACR, and then the recovery of the severe ACR. We also have some other comments about the role of EOs, and the ileum versus colon. Is there one area that you would like to focus on in the discussion about this, just so we use the time well? We could segue and talk about severe or these other issues. So Deanna, the group, I just want to have us use the time. We've got about 20 minutes before we move to the second section. So I think all of those are important topics. I think that grading, personally, I think Tom's question is a thoughtful one because, yeah. Phil.
Just as a point, unfortunately dating myself, but as you mentioned about the severe, it's very easy to, not easy, but it's recognizable, the labs. But typically in years past, we never saw them. Those patients typically did not do very well. But to Jen and her team's credit, now we're starting to see a lot more of these patients with regenerative changes. I mean, they're amazingly wild-looking biopsies, all sorts of things. So I think that's probably an important aspect of another subcategory under severe to me, because it just looks like healing bowel, but maybe in the context of autoimmunity it might be an important consideration.
Is there guidance that we can give as far as when you should biopsy again? Like if the patient is either the same or improving, when do you rebiopsy to check on the status versus they're actually getting worse, then do you biopsy faster? Because, go ahead.
No, I think one of the important things that we've changed is that we decide what our treatment plan is and we stick to it, and then we wait. Because I think going back, even the data that we have provided Mihai, we over immunosuppressed a lot of patients because we would rebiopsy and rebiopsy and rebiopsy, and you get desperate. So we don't usually biopsy, even like if you start treatment, and we use strong treatment nowadays for severe rejection, so we would not rescope them earlier than a week, and then we wait. We wait and we say, okay, we're going to do CAMPATH and we're going to do this, we're going to do Thymo, and we do this, and whatever the protocol is, we don't change, and the patient either gets better or they don't. But we rather retransplant than over immunosuppress. So that's the question about how often do you biopsy, and are you going to change your plan if you continue to go on?
So what complications are you seeing when you were thinking historically you over immunosuppressed?
That's, as Dr. Lewis was saying, because they would be so immunosuppressed they would end up dying from an infection.
Okay, that's what I mean. What was the complication?
Yeah.
Just to, we have a very similar approach. We decide up front, have an issue, we'll treat severe ACR with Thymo, and they're sometimes docking steroids if they come in on a Saturday evening or something like that, but they're getting Thymo if it was severe up front. We commit to how much Thymo we're going to give, subject to the patient tolerating it, and then we sit it out. The only reason to biopsy sometimes is to try and decide the right time. There's a point of diminishing returns of continued immunosuppression. And the patients who survive the severe rejection are those who either recover from the severe rejection or can survive the entrectomy, and that timing is a difficult decision.
And just to that point, a lot of the times biopsy is done because the rest still not functioning. And even though morphologically there's reasonable changes, it's just not at that point. So that's one of the areas to me that's always been the most distressing. We can actually see almost normal looking bowel. It's just not clinically functional.
So there's no gut value to us for an acute biopsy in that setting. We might biopsy a week, 2 weeks after completing Thymo, because as long as the patient is stable, we're not rushing to take a graft out, but we don't, because even if we see some small island of regeneration, we're happy to wait in the stable patient. But that window of enterectomy is a limited window.
I think one of the interesting things too, forgive me for jumping in, but there are a few programs that have started to use infliximab, either occasionally or rather more than occasionally. And the question to me is, which patients would that be appropriate in then? So if you have ongoing inflammation and you have regeneration, is this an appropriate therapy, or are we just simply over immunosuppressing with the risk of death before retransplantation?
I think that the answer is probably easier when you commit to time or combat, because you go with them at least for 5 days as a minimum. The question is, what do you do when you start with steroids, where you know that you can up your treatment at some point, but you don't want to rush to quite massive immune suppression. And I think that's the question when you rescope again. And it goes back to the question is, how fast will you see response to steroids with some improvement in inflammation and the other findings? So this paper can potentially give you some information. I think we are missing a lot of data to support, although I think some of the centers are sitting on a fair amount of data that maybe help us to make those decisions. But the question is 3 days is too early or just right? I don't have the answer. I'm not sure that there's enough literature to give us that. I think that's where the question becomes a little bit harder to answer.
So back to Tom and Phil's suggestion about the severe rejection category. In terms of, it sounds like we can try to distinguish the acute initial onset versus a recovery phase. And so, Phil, do you recommend doing a severe B, type B, where there is evidence of regeneration, or how does the group want to call that?
We used to have a category called exfoliative. I remember Tom Cato writing a paper, but actually most of the time that was one of the clinics. So I was so category, I think that's fine, because maybe, we're starting to actually biopsy post severe rejection. So yeah, I mean, there's tremendous severe so maybe it's just a consideration.
Do you define it by a timeline? I'm sorry.
That's the whole point.
Yeah.
It was not by the timeline, and I think the important thing to remember is that we're not saying that the severe rejection episode is over just because we're seeing regeneration in one biopsy. So the bowel still may be completely exfoliated, and I still use exfoliators and I see it that way, but it may be completely exfoliated, and we just see one portion of biopsy, because that was the best, and they may have biopsy the best portion, which was probably the only portion that has regenerated epithelium, for all we know. So I think I prefer to use the word focal regeneration or regenerative changes episode of severe exfoliative rejection in parentheses. So that is part of the same process. It's repaired or trying to repair, whether it's going to improve the next biopsy, I don't know. It may improve, fine, that's great for the patient. If it doesn't, it's his chance that I saw the biopsy.
Can I just take a, so presumably focal integration can occur concurrently with focal ongoing inflammation or rejection?
Correct.
Dan, could you go back to to this classification again? Just want to note, just since we're editing this this classification, right now severe ACR, it says features of moderate ACR plus ulceration, malaritis or ABC. Now, one issue that we run into in the post biopsy phase is that we see still denudation or significant ulceration, but we don't see active apoptosis. And I think that is still, I think, Ranga, you often would still call it acute severe rejection, evidence of some regeneration. So I think, well, we're not seeing active apoptosis. So what does the group feel about those type of patients in terms of calling it active activity? When you recover from an ulcerative episode.
Apoptosis is basically not that useful. Severe.
It's not a quick cancer.
So then that's where in this recovery subclassification we can note that there doesn't need to be the apoptotic criteria, that's less relevant.
Aaron, for my notes, so you would treat severe acute rejection up front with steroids?
No, with the mild for instance. The question is whether you may stop sometimes consider steroids.
For the moderate, for sure.
How long do you wait before you restart?
But just for the notes, I think the idea of biopsy we're discussing now only for severe.
I see. So now we don't do the test.
Can I ask a related question to the pathologist? Is there evidence or data that mild or moderate rejection ever progresses to severe? We have not seen convincing evidence of it in our experience. We think, obviously, you think different.
Well, I want to go, again, historically, that's why the minor category was established, because there was more of those patients that progressed on severe. And it tended to be patients that had confluent, almost whole cryptic necrosis, but not at the severe, so that's where the category came up. Now, is that still holding up nowadays? It's a separate issue. I don't know if obviously moderates are treated much better today than.
Then your own question becomes relevant. If we think moderate progresses to severe, then the timing of biopsy becomes important for each of those stages.
And I think that's something to remember, keep in mind, because we've had cases where we've done exfoliative rejection, and then we say, let's go to the upper allograft and do a jejunal biopsy. And the jejunal shows only mild rejection. So what do you do now?
That's described the case.
Right. So the issue is now you're having discrepant in the patient. So we have to remember that rejection is segmental, can be segmental, and can be variable within the same bowel. So
Any final comments on this section of the current classification? Any other edits or changes?
I feel like it's severe rejection, and sometimes you see occasional cause of ulcer. Sometimes it's very difficult to distinguish from lamina propria with complete dropout. There is not necessarily, I mean, it's not completely like to fulfill the definition of ulcer, but it could kind of be more specific for rejection rather than regular ulcer from other causes.
Could get granulation to show appearance, I suppose, if it's not regenerating well. If that's what you're trying to
So
say.
what I'm trying to say, sometimes people call it ulcer, but it looks like lamina propria with complete dropout, and they confuse them with granulation. But it's still severe rejection, so it doesn't really make a rejection.
What the impact is of that dropout?
Histologically, again, you should distinguish, or there's a way to distinguish granulation tissue versus complete dropout.
no, I don't think we can sit and split hairs on
What they're both bad.
you know.
I was gonna say, that's my interpretation.
Yeah.
They're both bad.
The point is, you're not seeing any trips, you know, until the trips come back, you know, there's going to be no functionality in the bowel.
For example, in the CMV also, you couldn't see the lamina propria with complete dropout. So then you can't.
Sure. If you have crib dropout, and it's a diastolic looking biopsy, that's not a good sign either.
It's not a good sign, but it's more specific for rejection than for CMV or other types of cancers. And I feel like we don't distinguish it very well.
According to this, grade severe
Yes, you need also
Most people call it ulcer, but it's not necessarily ulcer.
right, but technically also, but it's also severe.
But it's a specific.
Right. So I think there's some production would be to, say, to take for a dropout and additional. According to this, this grading system, we don't know all of the that is.
Add or a complete dropout, or at least add or complete dropout.
Define that as a specific amount or area, or, because you could have a couple of crypts dropped out, right? So you're saying one whole tissue fragment without any epithelial elements? So then why isn't that an ulcer maybe?
Ulcers should be
Sometimes you see neuroendocrine tests,
I guess I would still just put it in the basket if it's an ulcer. And, I mean, but we can specify if you think that it actually makes a meaningful distinction, or if that's a confusing point. I just put it in the same basket.
And again, it's also the important thing is what you have in your biopsies. If you have 3 pieces with good, nice, proud epithelium and 1 piece is ulcerated, I'm not going to call it severe rejection. I'm going to call that with ulceration, and I need to find out the cause of the ulcer. It may be infectious, it may be ischemic, it may be anything. So you have to use it in the context of what you have and what the clinical patient's context is. So,
Thank you for that, Peter, thank you for the notes.
The charge my duties under great pressure.
So in part 2, we're going to talk about ABMR and inter-observer variability. I'd like to get everybody for a group picture before break time, because I know some people might have to leave right at 6. So if we get all the participants up to the corner here, we'll take a group photo and take a break for 2 minutes.
so why don't we